Hello, I'm Tia Pederson, and I'm a physical therapist here at M Health Fairview, and I've been in the Wyoming Lakes Hospital, so it's not halfway to Duluth, just so you know. But I am on the north end of the cities. I've been a physical therapist at Fairview for 24 years now. I've been a public health therapist for about 27 years, and I've been a physical therapist for 33 years. That's a long time. Yeah, my specialty is women's health, men's health, and pediatric pelvic health. So that's kind of it for me. My connection with breast cancer is my mom was diagnosed with breast cancer at the age of 52. She survived. Unfortunately, for other reasons, she's not with us any longer. And I was not a pelvic floor therapist at the time. So, no, I did not discuss sexual health with my mother.
All right, my name is Arianna Larson. I am a physical therapist. I also work for M Health Fairview. I've worked for Fairview for about 5 years, and I work actually just like right over there at our University Village clinic. I did our physical therapy residency program. We have 2 residents per year who go through a women's health residency program, and breast cancer physical therapy is one of the main topics that we cover in our residency curriculum. My tie to breast cancer is that my mom also had breast cancer, lots of family members, and I did actually talk with my mom about sexual health. So that is, sometimes a interesting, weird topic to cover. So I hope that this can be a conversation. If you guys have any questions, I think we're both pretty comfortable in like talking about it. And a big move to try to talk more about sexual health in all of our patient population, but especially our breast cancer survivorship population. So just a few disclaimers here. We know that research is lacking in some areas. We know that all breast cancer, people that have breast cancer and survivors are not all assigned female at birth. And so we just want to say that in this presentation, when we say women, we're talking about those assigned female at birth, as that is what a lot of the research focuses on. We have no other financial disclosures except that we do have a paid membership to use some of the pictures in this presentation. So let's start it off with some foreplay, because we all know good foreplay is very important for sexual activity. So we actually have some questions for y'all, and if you would be willing to answer, that would be great. We do have some free prizes, some free lubricant samples. So ask good questions and you never know what you might wind up with. So first question, how many of you were asked about sexual health during your course of care? Great. Good. I mean, I think that this is a little biased because of where we are. And I know that we have really good clinicians that are asking these questions and talking about it with our patients as we see them in our clinic, which is great. And we love that. But I don't think that's necessarily the case throughout the entire country, talking about sexual health. How many of you wished you were asked about sexual health during your course of care? Yeah. And then what words might come to mind when thinking about sex during and after breast cancer diagnosis? Yeah, awkward. Painful. Awkward, painful. What else did I miss? Too tired.
Non-existent.
Non-existent. Dry.
Tight.
Anything else? Yeah, absolutely. Those are all things that we hear every day, and there is help for those things. So know that you're not alone, but there is also help for those things. And then what are your primary concerns with sexual health following cancer? Does anybody have anything that they want to shout out that
what are you hoping might to learn today?
Talk about? Yeah, what are you hoping to learn? Genital urinary genital urinary syndrome of menopause. Yes, yes.
um, like sexual pleasure, orgasm,
Yes.
that aspect of it. Also, as a single person, maintaining my sexual health. Like I think, and I've been thinking about that. She was talking about how things will narrow and it's more difficult. So like what can we do to maintain the health of our vaginas, even if we're single?
Yeah, amazing. Those are great questions that
I think Arianna paid you because that's what we're going to talk about.
Yeah. Great. Thank you. Thank you for being here. I hope that we cover, I think that we will cover both of those things, but if we don't cover that at the end, please ask again. Yeah.
What do we do about libido that just won't come back? Like it's just gone.
Yeah. Yeah. Great. That's awesome. We'll also cover that.
Hang on, because we're going to talk.
I don't know if this is in the realm, but just like talking to your partner about I don't know. My experience is they're like, everything's fine, everything's great, I don't care. And it's like, I don't know. How do you get deeper? Maybe bad choice of words, but
We will cover some phases, stages, and some treatment ideas for that.
But I will say it's like probably a really tough conversation to have. And I think just like having some facts, maybe even from this conversation today, to bring back to a partner is super important. So part of the things that we talk about are how we can have those conversations with partners, or if we need help bringing somebody else in, like sex therapy or something too, to talk about that along the way.
I'd like to talk about, and this might not be the right place, but how we can support medical practitioners in bringing it up. My husband had a prostatectomy while I was in the middle of chemo, and we noticed a significant difference in how sexual health was addressed with him versus how it was addressed with me. So I can't even tell you the difference. So how we support both women to be advocates for themselves, to ask. I was shut down once when I asked about it during nobody here at Fairview, nobody at the U, with a plastic surgeon. And so just how we support, encourage practitioners to be able to ask, and really how we encourage women to be advocates that it's okay to ask about this even when you're facing the decision about a mastectomy versus a lumpectomy.
Yeah, that's a great note. Thank you. That's very frustrating for us to hear as well. But I think it falls on us as providers to keep talking about it, keep bringing it up, keep having these conversations. Also really encourage all of y'all to advocate for yourselves as much as you can, as hard as that might be. I always appreciate it when people are asking those questions. I'm usually the one to bring it up, but it's really important. And even just, I love it when patients are like, thank you for asking. So hearing that from patients is super nice too.
Additionally, how many of you knew that there was pelvic floor therapy? Yay!
Amazing. Good. Okay. All right. Well, let's jump into what is sexual health. So World Health Organization defines sexual health as a state of physical, emotional, mental, social well-being in relation to sexuality, and not merely the absence of disease, dysfunction, or infirmity. So we think that sexual function is considered a human right. And a lot of the findings, a lot of the research is saying that, sexual health and related concerns are a major need among breast cancer survivors, but it is largely unaddressed. So we're going to keep working on changing that. Psychological and sexual disorders are common in breast cancer survivors and can diminish their quality of life. This is just one of many quotes that I found in research that we need to keep talking about and looking at, but this was looking at some of the like psychological and sexual dysfunction in long-term breast cancer survivors. So here are some of the facts, some numbers that maybe we're not as interested in, but I need to set the stage a little bit on what research and literature are currently saying about sexual health. So looking at the first article on the left, this was an article looking at sexual health of female breast cancer survivors and their partners. So they interviewed both the patient and their partner and talking about their sexual satisfaction. And both patient and partner reported lower sexual satisfaction during and after breast cancer diagnosis. 75% of participants, both patient and partner, report not knowing about sexual health issues related to breast cancer. That's a big number. We need to do better about educating people with breast cancer about sexual health and how they may be impacted. Looking at the far right study, this was looking at the incidence and severity of sexual dysfunction among women with breast cancer, so a meta-analysis. This was found that about 74% of breast cancer patients reported some severity of female sexual dysfunction. And the overall sexual function in women with breast cancer was significantly worse than those when compared to those women without breast cancer. Going back to the middle article, this was a longitudinal study of breast cancer survivors that looked at their sexual satisfaction scores from the time of their diagnosis through 4 years after. About 78% of participants reported at least one sexual concern between 0 to 4 years after diagnosis. And then just thinking about that, like how many of those 20% haven't even tried being sexually active, right? For fear or whatever else might be going on. And then 46% of participants reported not using any sort of supportive care strategies. This is a graph from that article looking at the different things that they were, that the participants were given studies on. So body image, sexual inactivity, poor sexual function, and poor sexual enjoyment. One of the big things that was interesting to me in this study was poor body image at the time of diagnosis was 32% and went up to 57.8% after 1 year of diagnosis. So just thinking about body image and the changes that y'all go through with a breast cancer diagnosis and how your body changes. We know that there can be lots of changes happening. And so obviously a poor body image has been shown to lead to decreased sexual health satisfaction. So something really important to talk about and continue to, talk about your body image and get to know like the new parts of your body after going through your treatment. Sexual health is an integral and fundamental part of being human and an integral component of health-related quality of life. A cancer diagnosis does not negate this, and patients should not be left to assume that wanting to maintain a sexual life is no longer part of their reality. So just another quote that we thought was very important. So alterations due to cancer treatment can challenge a woman's sense of femininity and lead to reduced self-esteem, feeling of unattractiveness, shame, and sexual withdrawal. Surgical treatment may lead to asymmetry, fibrosis, scarring, lymphedema, sensory loss, pain in the breast area, body image concerns. We know that loss of sensation potentially due to removing of the nipple, breast, or chest, we know that that can be an important part of sexual satisfaction. So if you are a person that has had something of that sort removed, that might have a negative impact on your sexual satisfaction. So looking at how we can change that sexual satisfaction is going to be really important after that surgery. Radiotherapy may moderately affect sexual activity due to fatigue, sleep disturbances, pain, potential for that loss of nipple sensation or the skin type of disorders. And then also just thinking about mobility and how radiation can affect how you're moving.
And the hip bone's connected to the knee bone. Everything is connected in the body.
Yes,
So,
very important.
so when we have breast cancer diagnosis, it is connected to the rest of you.
Chemotherapy is a key risk factor for sexual dysfunction, particularly regarding arousal, lubrication, orgasm, and pain during intercourse. The toxicity of chemotherapy can lead to mucosal damage, alopecia, nausea, fatigue, ovarian insufficiency, which could potentially result in any sort of chemotherapy-induced menopause, amongst other. And so that was the genitourinary syndrome of menopause that Jenny was talking about earlier. And so with menopause, how I usually explain it to my patients is genitourinary syndrome menopause is just the effect on the vulvovaginal tissues. So a lot of symptoms that we see with that are urinary urgency, potential for urinary tract infection, urinary incontinence, decreased arousal, decreased libido, decreased plumpness to the tissues in the vaginal and vulvar area. It's very lovely, right? And then also chemotherapy, treatment-related weight gain, fatigue, neuropathy, and then pelvic floor problems, which we'll get to in 1 second. Endocrine therapies are associated with various adverse effects, which can also affect sexual well-being. Hot flashes, reduced sexual desire, weight gain, musculoskeletal pain, depression, cognitive impairment, and fatigue. And so in those premenopausal women diagnosed with breast cancer, these effects may be even more pronounced due to that abrupt estrogen depletion and forcing you into that like premature menopause. So this is sexual dysfunction in those with a vagina following cancer treatment. A lot of these go with the genitourinary syndrome of menopause. So vulvovaginal and clitoral atrophy, which basically just think about like the tissues getting smaller, not as plump. Vaginal thinning, decreased elasticity, dryness, dyspareunia. Dyspareunia is pain with any sort of penetration. So that could be pelvic exam, tampon, any sort of like sexual activity penetration. Reduced vaginal size and vaginal lubrication, suppressed libido and arousal. And then also if there's any sort of hysterectomy, that can have an impact on sexual health as well, with the scar tissue in that area, and then the hormonal impact as well, depending on what type of surgery you have. So the Clinical Oncology Academy recommendations for those with any sort of cancer: we should have discussions with patients regarding sexual health and dysfunction at the time of diagnosis and throughout follow-up, offering of any sort of like psychosocial or psychosexual counseling, body image counseling, which may be, you know, talk therapy, support groups, that sort of thing. Hormone therapy, as Jenny talked about, very important and something that we usually refer a lot of our patients if we notice any sort of that like atrophy in our patients, refer to your oncologist or gynecologist, midwife. Very important, but not something that we can give to patients. Lubricants, we'll talk about that, vaginal dilators, and then pelvic floor exercises. So pelvic floor exercises, what are they? I'm sure everybody's heard of a Kegel before. So let's talk about the anatomy of the pelvic floor. So first, let's look from the outside in. We have just our generalized hip musculature here. You can see the complexity of the area. You have hip flexors, your glutes. All the surrounding musculature is helping to give support to your pelvic girdle. And so if you don't have a strong support system here through your abdomen and through your hip musculature, that can definitely have an impact on pelvic floor. And we know that those who are going through a cancer treatment are a lot of times feeling more fatigued and weak. And so it's very important just to make sure that we're staying active and trying to get these muscles activated to keep up that strength and stability as much as we can to help the pelvic floor. And the pelvic floor, looking from the bottom up, you will see the different layers of the pelvic floor. So the pelvic floor is a group of muscles that helps to give support and stability to the pelvis. So supporting the organs, supporting whatever organs you might have in your pelvis. So bladder, vagina, uterus, rectum are one of the main functions of the pelvic floor is to support those muscles. I often think of it as like a sling or hammock that holds everything up. And then stability. So these muscles also help to give stability to the entire pelvic girdle. The muscles also help with sphincter control. So urethral and anal sphincters helping to open and close those. Sump pump, so there's 5 S's: support, stability, sphincter, sump pump, and sexual function. So sump pump is just like helping get fluids out of the area if there were swelling. And then sexual function, which is coming up here in 1 second. On the left, you'll see also a bottom down look at the pelvic floor muscles. And then on the right, you'll see a top down approach. So you can see how closely the pelvic floor and the hip musculature sit to each other. And so that's why it's really important that we're looking at how your hips are moving and testing strength there as well. This is just the external female anatomy that we're usually looking at to make sure that things are moving, functioning properly. We're looking at your tissue, how the clitoral hood is moving, and just making sure that everything looks good there, as well as it's a part, you have a more superficial part of your pelvic floor that we assess from the outside. So how pelvic floor functions, a quick and easy way of thinking of it for sexual function is we need relaxation of the muscles for blood flow to get into the erectile tissues of the clitoris. We also, or penis or whatever other sort of erectile tissue, we need relaxation of the muscles for any sort of penetration. We need some squeeze of the muscles to help maintain that arousal. And then we need squeeze relax for orgasm, because orgasm is an involuntary contraction of your pelvic floor muscles. And so we need the muscles to be functioning to squeeze, we need them to be functioning to relax, and then we also need coordination between them for all of those functions of the pelvic floor to work as they should. Obviously, the pelvic floor doesn't always work as it should, and there is things that we can do for that. But specifically looking at just sexual function, obviously it's more complex than muscles. You have your, blood flow and nervous system. We all have to kind of talk together to get that like normal sexual function, and normal looks different for anybody else. So all 3 of these different pathways that you see here can be normal for a certain person. So the first phase of sexual response is that excitement. That's that initial like relaxation, blood flow coming into the genital tissues. Plateau is getting up to right before you're about to reach the orgasm point. Some people can't get past that orgasm point, and that is a common side effect of those who are decreasing or lacking estrogen to those tissues, or maybe the pelvic floor isn't working how it's supposed to. And then orgasm, again, the involuntary contraction of the muscles. And then with resolution, we need the muscles to help relax to get you the blood flow out of the area and get you kind of back down to baseline. This is the fear avoidance model. This is specifically looking at penetration of the vagina. And so a lot of times in folks that have a penetration attempt that's maybe not comfortable because there's dryness to the area, or the pelvic floor muscles are tensing and tightening up because there's nerves there, or it's been painful in the past, there is potentially that negative experience, and that can lead to those catastrophizing thoughts. So looking at the left side here, which can then lead to fear of penetration, more pain, which then either potentially avoiding the activity altogether, or hypervigilance, which then leads to pelvic floor muscle tension, which then just makes everything worse because it's a vicious cycle, right? And so if the muscles are tense and tight, attempt penetration again, it's going to be uncomfortable. So that is part of our job, is to try to get you out of this cycle, find ways to slowly get you back into penetration or whatever other sexual activity that you might be looking to do. So hopefully that is something that we can do in pelvic floor therapy. If not, we also make sure that we're sending you to the right place as far as referrals go. So we'll move on to Tia and what pelvic floor therapy is.
With a few jump-ins from Arianna, I'm sure. So what is pelvic floor therapy? I tell most of my patients it's very similar to regular physical therapy because we are kind of the muscle whisperers, and that's what we deal with. But this muscle happens to be in an inopportune spot. So we start our therapy sessions with getting a good subjective history of you. Why is that important? You are more than your diagnosis. We need to know your lifestyle. We need to know how were you before your symptoms started. What is the baseline that we're trying to get back to, or what are we trying to achieve that we've maybe never even achieved? So the orthopedic evaluation is going to assess your posture, your tissue health, motion of your entire body, not just that pelvic floor, strength and function throughout your body as well. I'll go into a little bit more on what that examination is in a future slide here. So for our assessment portion, we're trying to understand your specific dysfunction. That may be that you have a short, tight muscle. That may be that you're poorly coordinating your muscles. You may have a weak muscle. We know what needs to happen, like elongating your muscle, learning to control the tension, need to strengthen. And then we base that on your dysfunction as far as what our plan is for treatment. So coming up with that plan, the plan is going to be your roadmap to your home exercises. It may be suggested interventions, which might be manual therapy, biofeedback, and also probably a predicted number of treatment sessions. So the pelvic floor examination, what is that going to entail? Both the external and the internal examination. So the external exam, we're looking for impairments in your abdomen, your low back, your hips, your sacral area, your thighs. We're looking for range of motion restrictions, strength limitations, flexibility issues, connective tissue issues. I never knew what that sounded like until I said it out loud. Trigger points, we're looking for sensation issues, anatomical alignment, your gait or walking pattern, a skin inspection, and pelvic muscle contraction. That's all the external stuff we look at. Then we go to the internal exam, which may be a vaginal or rectal, just depending on what we need to do or what we see in the external exam. We're again assessing for trigger points, assessing for tone of your muscle. We're going to grade your strength on a 0 to 5 scale. We call it the PER scale, so it's power, endurance, repetitions, and fast twitch muscle contractions. We're looking at muscle symmetry. Are you similar right to left, front to back? We're going to look for that. Palpation, that means touching or manually assessing the tissues. We're looking for any prolapse, which happens to be if you have tissue falling through your vaginal cavity. Yes, that is something, if you've not heard of that, that's something physical therapy can deal with to a certain degree. We are looking with you in that prolapse situation in a bearing down position of Valsalva, which is kind of that holding your breath and bearing down, and with a cough. We're assessing for paradoxical contractions, which means is your stomach muscle and your pelvic floor coordinating, or are they fighting each other, or are they not listening or talking to each other, trying to make a coordinated effort? And then we're also assessing for coccyx or tailbone movement. This is a very comprehensive look at you. It's pretty discreet but complete. We try to maintain modesty as best we can, but we are pretty in-depth. So physical therapy treatment considerations, we do manual techniques, which means using our hands. We have therapeutic exercises for specific pelvic floor strengthening or relaxation, depending on that exam, what your body needs is what we're going to focus on. We're also going to be looking at your pelvic alignment, your hip capsular mobility, your abdominal and pelvic fascia, your external and internal muscles. We look at your lifestyle. Oftentimes this is involving looking at your behavioral and dietary habits and seeing if we need to make any changes. When I say for irritants, sometimes that's more for a patient who also suffers incontinence in addition to any sexual dysfunction. A bowel and bladder, time voiding, and urge control strategies. Those are all lifestyle changes that we talk about and educate and try to make changes for the better. The tools that we use, you may have heard of biofeedback. That is a way that we can have you as a patient look back on your body and learn from that experience, trying to coordinate and use your muscles more efficiently. Rehabilitative ultrasound imaging is very similar. I call it to the baby ultrasound. If you've ever had an ultrasound of your abdomen for during pregnancy, we can see the baby. Well, we can look at other things in there as well. So we look at your pelvic floor through your bladder. We can do I call it a bottom end ultrasound. And I had a video in here coming up, but we weren't able to play it. So I'll talk about what we are supposed to be able to see when we come to that video. And then we have pelvic floor training devices, which we will get into here in a minute. Our manual techniques can be external or internal, or both. What we do in those manual techniques is we're actually stretching your muscles. We might be doing some myofascial release techniques, scar massage. We're trying to affect your tissue to improve the function. And that may include improving your circulation, improving the mobility, and working specifically on pain reduction. So myofascial release is a special technique that we use to release your fascia. Does anybody know what your fascia is? Anybody had plantar fasciitis? Okay. If we skinned you, and we really wouldn't, but if we skinned you and looked at what's underneath your skin, you would have kind of a whitish covering over everything, okay? That's your fascia. Fascia is around muscles, around organs, around blood vessels. Fascia works to stabilize things. Fascia works to improve mobility in things. So fascia is a pretty standard component in any part of your body. And when it doesn't work well, that's where we come in and try to help it along. When you hear of a fasciitis, that's an inflammation of your fascia, very painful. Itis is sticky, so things don't work well when that fascia does get stuck together. And after a breast cancer procedure, any of the reconstruction, there's a lot of fascia that's disrupted. So we technically work on the abdominal fascia and the perineal fascia as our primary focus in this treatment. So fascial tissue changes as a result of these surgical procedures, and these changes result in decreased function. There can be scarring. Hypomobility means things aren't moving well. There can be edema. When things don't move well, your fluid doesn't move well, and it can pocket in areas, and that's why we get some of that edematous conditions going on. And then pain. If something doesn't move right, if it's your fascia not moving and your muscle is trying to make it move, there's a disconnect there, and that tension that is developed is going to be painful. Myofascial release techniques for sexual dysfunction, again, will occur in the abdomen and the perineal area. So pelvic floor coordination and control is us teaching you the exercises to gain this. So people with pelvic pain commonly don't need Kegel exercises, okay? If your muscle is sore, I'm not gonna ask you to work it all the harder, okay? But all people with symptoms do need the ability to be aware of the pelvic floor and be able to let go of that tension or guarding. So if you have a tight muscle, I'm not going to ask you to make it a lot tighter. I may ask you to contract it so you can do the opposite of it. Okay, so if you have a tight muscle, I can say, I always use the example of a patient coming into the doctor and saying, I have a headache, but I don't know why. Okay. After a while, you're so used to being tight and tense, you don't know this is what you look like. Okay. The doctor is going to say you need to relax. And they say, I am. Okay. I don't know how to relax. But if I say, tighten up your shoulders, and they say, well, I can't. Okay. We'll do the opposite. Oh, I had more to give there. Okay. So sometimes using some analogies like that are a little bit easier to understand what's going on at your pelvic floor. So we also know research shows that 3 maximal contractions of the pelvic floor are shown to reduce vaginal resting tone in biofeedback readings in women that have vestibulodynia or vaginal opening perineal pain. Does everybody know how to do a Kegel? Okay, I tell all of my women patients, if you've had a baby, there's a nurse that told you, okay, honey, you gotta do your Kegels. And we all obediently say, okay. Do we have a clue what that is? Does the nurse have a clue? Maybe, but we don't talk about it. So like you had said that, you know, your husband got all of this information. We as women oftentimes are expected to know that just because we're women. So a Kegel exercise, I tell my patients the easiest way for me to explain it in a quick and easy fashion is pretend you're in church or the library and you had Mexican food last night. You have to pass wind, okay? You don't want to. You don't want to be the person that's clenching and rising up in your seat. Wrong muscle. That's your butt cheeks, okay? It's inside. I tell my patients, if you were to take a mirror and look at your pelvic floor when you do a Kegel exercise, if this is your sphincter, that is it. Did y'all see that? Okay, we are not trying to make diamonds out of coal down there, okay? So you just have to be aware of closing that door and being able to open it. For all intents purposes that we're doing with the sexual function and the tight pelvic floor muscles, oftentimes we're just trying to get you to be aware of that sphincter control and trying to be able to relax it just as well as you can contract it. So it is important for the pelvic floor muscle to be assessed for awareness and coordination. And that again, maybe including us taking our fingers and assessing you, maybe just watching what that muscle can do, maybe using some biofeedback and ultrasound tools, because all of these things are going to be all inclusive for your care. So this is where my video was, and it works. Hallelujah, you did it. Okay, yay. So that model over there, the sagittal one, when we do an ultrasound on you, pretend this is my ultrasound wand. I know it isn't, but for intent purposes, try to think of it as this. You would be lying on your back and we would be putting the ultrasound wand on the outside, kind of right on your pelvic floor. Okay, so the computer with the ultrasound is going to show you that type of an image. So the video that I have here is a patient of mine, a person with a vagina that is doing a contraction, a relax to baseline, and then doing a bulge or a bear down type of a motion. All three motions need to be there for us to have great sexual function in our pelvic floor. So here is that video. Hopefully you guys can see this. They're contracting, relaxing to baseline, and now bearing down. Pretty cool, right? That's a hard thing for people to feel if they can't see it. Okay. So sometimes when those motions aren't happening, we can do exercises. I'll get into the manual techniques, but sometimes starting out with some conservative techniques, like just simply learning how to breathe again through your abdomen and your pelvis, is a way that you can get range of motion into that pelvic floor. Okay. So diaphragm breathing means you are going to be breathing using your diaphragm a little bit more effectively. People who don't use their diaphragm effectively are very upper chest breathers. You see a lot of movement in their chest, okay? In America, I guess the world now, we are all designed to hold it in, keep it tight, look svelte and skinny, okay? We are told not to use our abdominal muscles very much, okay, especially in just natural posture when we're walking around. So as a breathing exercise, we need to make sure that that motion is still available to us. So diaphragm breathing is what we tell patients to do, enhancing that respiratory diaphragm use. The benefits of it, sometimes if you guys have ever had any like stress management therapy, or maybe you've been on social media and somebody says, I can't fall asleep, try a breathing exercise. Okay, it regulates your central nervous system, takes down some of your anxiety, and does have a calming effect. Diaphragm breathing also expands your abdominal wall range of motion. It can help with your pelvic floor relaxation because your respiratory diaphragm and your pelvic floor kind of work like a piston, okay? If one is going up, the other kind of goes with it, or at least it's supposed to. And when it goes down, the other can go down with it as well. If one of those is not functioning well, it's highly likely the other one is not going to function as well either, okay? It also, diaphragm breathing facilitates peristalsis, which means the intestinal motility, being able to poop. If your abdomen is not working well, your muscles are kind of like acting like a tourniquet in the center of you. You're not going to have great circulation to your pelvic floor. Your intestines are going to have a tough time moving poop through. It's bad news bears. Okay. So trying to get your abdomen to work better is like taking a tourniquet off the middle of your body. Your body will feel a lot of relief. You'll just feel better, a lot of tension release. So sometimes when we start talking about diaphragm breathing and people try it, they get very frustrated because they can't do it well. And it brings on anxiety because the therapist is watching me and they're supposed to know how to do this. And so we can try other techniques to make this diaphragm breathing go a little bit easier. And one is putting weight on your belly. We just put a simple weight, usually about 2 to 5 pounds to start with. And we say breathe and lift the weight. Okay. That naturally will bring in some of that abdominal motion, and that abdominal motion will also call up your respiratory diaphragm motion as well. Try it in prone, which means lying on your stomach. For kids, because again, I treat kids for pelvic floor, we call it crocodile breathing, because crocodiles, if you see them, their sides kind of go out. Okay, so when you lay on your side and try diaphragm breathing, you'll see a little bit more expansion out to the side, and that's also improving that abdominal range of motion. 4-7-8 breathing. Has anybody tried that? Yeah. It works once you master it. Trust me, I try it before I go to bed sometimes because it's supposed to help me fall asleep. First few times I tried it, breathe into 4. Hold on to it for 7. Breathe out for 8. Okay. It takes practice. Did you have a question? I love it. Awesome. I love it when I can learn things as well. So thank you. I will have to try that. So I think this video isn't working, but this is our diaphragm breathing video, and it does. We talk about putting a hand on your sternum and a hand on your belly, and when you breathe in through your nose, your belly rises. Breathing out through your mouth, your belly falls, and eventually the advanced portion of that is calling your pelvic floor to do a slight contraction on that exhale. Yeah, I still can't get it to move. Okay, so mobility, working on other parts of the body. The hips have to move, the low back has to move, your legs have to move in order to have a good pelvic floor function. So other things that you might be asked to do in physical therapy, or something that you might even looked at yourself, is yoga stretches. You may have been in low back physical therapy for other orthopedic reasons and learn hip joint mobilizations, lumbar spine mobilizations, and repeated lumbar movements. These are all general physical therapy things that we can do in addition to the specific pelvic floor. So what can you do as a patient? In addition to the home exercises, working on your stretching, working on your diaphragm breathing, getting your hips and pelvis mobile, we have dilators. We have pelvic wands. Those are things that we teach you how to use at home. We have pain relief techniques. You guys have talked about not being able to really sense much going on in your pelvic floor. So we have a sensate focus that we'll cover here in a second. Sex positions make a difference. If your muscles are tight, there's only certain ways that things can go into your pelvis based on tight muscle directing it. So learning what that is in your own body and learning how to control those tight muscles in certain positions is helpful. Vaginal moisturizers, vaginal estrogen, lubricants. We've got some lovely samples for you guys. Feel free to take some when you leave. I think we were going to throw them out if you guys ask questions and try to pelt you with them, but so we're running out of time. We have too much to tell you guys.
Maybe leave this one on.
Okay. that work? That works. So go through the dilators.
We're going to try to get through as much as we can in a couple minutes here, but dilators are basically gradual exposure to vaginal penetration. And so we have one set here. They come in lots of different sizes and types of material. These are made out of silicone, which are generally more comfortable, especially for those people who have more like vaginal dryness, irritation, that sort of thing. And then also we need to make sure that we're using a water-based lubricant with anything that's silicone, because we can't be using silicone lubricant with a silicone device. This is a hard plastic dilator, which sometimes they give you at the doctor's office. Not the most comfortable or fun looking thing ever. They come in different sizes as well. So basically you're just gradually working up to the size that you might need. These are wands. And so these are something that you insert into either the vagina or rectum to try to release the pelvic floor muscles. So that is something that we usually have you bring into pelvic floor therapy, and we work on that together to try to get those muscles to release, and something that you can do at home on your own as well. This is a bendable one, kind of moves around a little bit. I'll get to the good stuff of what people really want to know is that lubricant, if you want to pull up the lubricant slide, lubricant, there's lots of different kinds of lubricant. Water-based lubricant is usually what we're using with the dilators. It is just like vaginal tissue and lubrication. So most closely representative of that. Some cons are that it can dry out very quickly. Silicone lubricant, you have to make sure that you're using a good like high grade silicone. It tends to coat the tissue a little bit better. And so sometimes in people that have dryness and irritation, it is a little bit more helpful to have a silicone. It just requires soap and water cleanup and can stain. And then there's also oil-based lubricants that are also sometimes kind of nice because they can have moisturizing properties. They also have lubricants that have like hyaluronic acid, which can be moisturizing. And then there's also vaginal moisturizers out there as well that you can use to help to lubricate those tissues. Big things with lubricants and moisturizers is that you don't want to use anything that has parabens or glycerins in it. We have some other fun stuff up here, but I think we're probably out of time. I'm happy to stay and answer questions during lunch, if that is cool. Yeah, okay. I'll leave our little display up and
so there were other techniques that we were going to talk about, like mindful masturbation and sensate focus, learning what your body looks like, feels like, so you can discuss that with your partner. If you don't know, they're not going to know. So we do that in physical therapy where we train those muscles or train you to learn what your muscles are supposed to do, what they're supposed to feel like, and we walk you through that process. Sex positioning we talked about. Sex therapy, I think, cognitive behavioral therapy. We have a few local resources. So if you guys have access to our program after this, you can look this up on your own. That's all.